We're good.
Good morning and welcome to the latest in our Colorful Conversation series with the West Hartford Chamber of Commerce. I'm Chris Conway, Executive Director of the West Hartford Chamber of Commerce. Today's program is brought to you by our Minority Business Network. Colorful Conversations is a quarterly panel discussion that we host here at the Chamber. And today's topic is access to healthcare in communities of color. I would like to thank our sponsors for this event, Liberty Bank, the North Star Realtors, and Comcast Business. It is now my pleasure to introduce the chairman of Minority Business Network, Chris Clark, who will serve as moderator for today's discussion and will introduce our panelists. Thank you.
Thank you so much, Chris. It is an honor and a privilege to be your moderator today. I'm Chris Clark, chairman of the Minority Business Network here in West Hartford. And as Chris mentioned, the Colorful Conversations is a quarterly series that highlights topics of interest and their impacts on communities of color. I don't want to spend a lot of time introducing myself. I would love to have the opportunity to give our guest speakers an opportunity to introduce themselves, tell you a bit about who they are, what they do, and their areas of expertise. Ken, we'll start with you, please. Or you're on mute.
Thank you so much, Chris. First, let me thank the Minority Business Network and the West Hartford Chamber of Commerce for hosting this very important conversation regarding health disparities in the greater Hartford community. I am Kenneth McCleary, Regional Deputy Vice President for the Eastern Region at Community Health Centers, Inc., which is a federally qualified health center. The Eastern Region covers the northeast region of the state from Enfield all the way down to Groton. A little bit about Community Health Centers, Inc. Community Health Centers, Inc. Is a world-class primary care organization committed to serving special populations, improving health outcomes, and building healthy communities through our clinical excellence, our research and innovation, and training of our next generation of healthcare workers. CHC was co-founded in 1972 by our current CEO, Mark Maselli, under the principles that healthcare is a right and not a privilege. And that continues to inform the work and drive our work that we're doing today. As a result, Community Health Center has become the leading independent nonprofit healthcare provider and one of the leading healthcare providers in the state of Connecticut. We provide primary and comprehensive care services in medicine, dentistry, and behavioral health to more than 145,000 people across the state. And I'm, again, so happy to be here. And thank you to the West Hartford Chamber and the Minority Business Network for having me today.
Well, thank you again for joining us. Vasant, would you like to introduce yourself to the audience?
Sure. Thanks again to West Hartford Chamber. So Vasant Kankuriam, I'm a triple board certified physician, internal medicine, pediatrics, and obesity medicine. And I consider myself a doctorpreneur, doctor first, businessman second, founder of 4 Elements Direct Primary Care. So 4 Elements DPC, it's an affordable, disruptive, copay-free primary care model. We take care of adults and children through just a low monthly membership fee that starts at $35 a month. And that includes all of your office visits, email, texting, phone calls, telehealth. So it doesn't depend on insurance. So many of my patients have insurance, private, Medicare, Medicaid, and many of my patients do not. Many of my patients are undocumented immigrants. Many of my patients are business owners that are just trying to get great care. So it's a huge, diverse population. I tell people it's like old school medicine. So imagine your doctor and the relationship you had 70 years ago and turn that into a very modern Amazon Prime-ish type of experience. And I even do house calls. So it's a lot of fun. My patients spend a lot more time with me, an hour, sometimes 2 hours. So it's a really relationship-based, old school primary care model. And like I said, my patients get direct access to me with no copays ever. And as part of the model, also offer lower costs on lab tests, medications, imaging studies. So really very local and independent. So that's what I do. Thanks for having me.
No, thank you for joining us, and thank you for sharing a bit about your company, because we'll definitely do a deeper dive into that in a moment. And Peter, please tell us a bit about yourself and what you do, as
Sure.
if the world doesn't know already.
I'm Peter Hotez. I'm a professor of pediatrics and molecular virology here in Texas at the Baylor College of Medicine and Texas Children's Hospital, which is part of our Texas Medical Center. And I'm also an academic. I'm a dean of our National School of Tropical Medicine, lifelong interest in studying diseases of poverty across the world, developing new vaccines that the big pharma companies won't make. So I'm in our Center for Vaccine Development. We've made new vaccines for diseases such as schistosomiasis in Africa that affects 40 million girls and women living in poverty, a condition known as female genital schistosomiasis, a new Chagas disease vaccine, a hookworm vaccine. And now we've also about 10 years ago started a coronavirus vaccine program. And now we have a new COVID-19 vaccine that should be released for emergency use in India next month. This is a low cost recombinant protein vaccine that the biological ER collaborators is making as 100 million doses a month. We've also licensed it to Indonesia to make a halal version for Muslim majority countries across Africa and Asia. The other interesting piece of this is I was born in Hartford and grew up in West Hartford and went to Hall High School and survived that experience. As a kid, I would collect pond water and brook water across a small brook that was off Mountain Road in West Hartford and began looking under the microscope. And that's how it all started, going to the West Hartford Public Library and in West Hartford Center and the North End branch, so a lifelong Connecticut resident up until I was 18. Well, then I went to Yale College and then went to New York for my MD and PhD. So anytime I get an invitation to come home, and I guess virtually these days, I try to take up on that offer.
See, hometown boy makes good, right? And we appreciate you taking the time, because I know that the clock is a little different in Texas right now. We appreciate you making the time to come back and have this conversation with us and share some of your experiences and insights into healthcare. Yeah, and I guess that leads into the first question, because for many Americans, understanding our healthcare system can be like learning a foreign language. Yeah. So what steps would you, as healthcare professionals and with your vast knowledge and experience in the field, what steps would you recommend that the average person take to better navigate our healthcare system? And anyone can feel free to jump in.
Well, I'll start. The other day, I think it was on MSNBC, I was talking about this extraordinary study that was done at the National Health Service out of the UK. They have recorded 40,000 brain scans, MRIs, before the pandemic, and they know who developed COVID, and now they can bring them back to determine if there's any before and after effects of COVID-19 on the brain. And sure enough, those studies led to the discovery that COVID-19 causes gray matter brain degeneration and cognitive declines, and we have to take long COVID very seriously as a condition. And of course, we cannot do that study in the United States because, in my moments of despair, I say the UK and Israel, they have a health system and we have Amazon pharmacy. We don't have a health system as we know it. And this has come back to haunt. I mean, one of the things that I think COVID-19 has done is exposed all of that, exposed every single weakness in our health system. And of course, who've borne the brunt of this failure are our BIPOC communities, are especially in low-income communities. I mean, here in Texas, it's the Hispanic communities just gotten decimated. Those living in South Texas, those living not even along the Mexico border, just across many parts of Texas. The community hospitals got quickly overwhelmed. There was lack of access to healthcare, lack of access to healthcare information. and the deaths were just extraordinary. And the narrative out there was always it's exclusively people over the age of 70. It's clearly not the case, at least in our Hispanic community. We lost so many mothers and fathers in their 40s, 50s, and 60s. So a whole generation now of orphaned teenagers and young adults. This will haunt us for a long time. So I got asked by our Texas delegation, Congresswoman Sylvia Garcia, also Congresswoman Escobar from the El Paso area, Sylvia Garcia from the Houston area, Joaquin Castro. And I've been talking with Beto O'Rourke quite a bit here. They asked me to testify to the Congressional Hispanic Caucus, and I just said it like it is, that this has caused historic decimation in the Hispanic community, not only in Texas, but across a whole segment of the country. And no one knows about it. And quite honestly, not many people even care about it. And I think this is one of the important messages. And then among African-American communities, again, hit very hard. So I'm on an advisory panel now with the Rockefeller Foundation to really look into this and trying to understand why we're still seeing vaccine hesitancy in the African-American community and the targeting of African-American communities that's going on by anti-vaccine groups, including this fake documentary that's circulating around. That's about as exploitative as you can imagine, of showing people of color getting their Pfizer-BioNTech vaccine. Then it switches over to these grainy images of Tuskegee experimentation in the 50s and 60s and trying to equate the two. It's as racist and exploitative as you can imagine, but that's what's out there. And so trying to fight that and trying to save our communities has been one of the, in addition to being a vaccine scientist, waking up every morning and doing what I can. And so one of the things that I've been doing is, in addition to working with the Congressional Hispanic Caucus, going on radio programming that will address Black and brown audiences and doing that on a regular basis. And I think that may be having an impact. I was on, and then I'll stop. I was on one recently with a historic Black church in Richmond, Virginia. And I was on with, it was a pediatrician named Dr. Freeman who invited me, and the pastor of the church was on. And, before we went live, I said, it looks to me like vaccine refusal and hesitancy is going down in communities of color. And he said, Pastor, what do you think about that? And I goes, he's definitely, it's still there clearly, but he is seeing some improvement. And I said, well, what do you ascribe that to? And I said, well, part of it is docs like you reaching out, but he offered the other piece to this is when the clergy in the Black churches saw what was happening, they reached out and they created this informal network where they were all speaking with each other. And I think that did a lot of good. And so this is why I do these kinds of Zoom calls, because it does have an impact. It does have an effect. I'll stop there.
So I'll piggyback off of what Dr. Oted said with the Black clergy, because in my former role at Trinity Health of New England, which is one of the largest health systems in the state of Connecticut, one of my jobs and my role was to deal with the communities of color and their hesitancies around the vaccines, not just the vaccines, but testing of the testing for COVID. And so he's spot on. What we did at Trinity, what I did at Trinity under the leadership of Dr. Reginald Eady was to go directly to the Black church. And what we did was what we call the snowflake effect, right? We had tons of COVID relief dollars and around education and the vaccines. And so I went directly to the Black clergy in the north end of Hartford. And I said, look, you can play a role in educating the communities around you. And so what we did was we gave each church to community health workers to do the door-to-door combat of their neighborhoods. We gave them the educational resources. We gave them access to all of the physicians, the nurses, practitioners, and said, hey, these folks are at your disposal. Whatever you need in educating your community, you have it. Not just that, what we did in the North End and in the South End was we pushed community clinics for vaccines. So we said each day you have 160 plus 72 appointments a day. And not just those appointments, but we are after a certain period, so we don't waste vaccines. We're going to allow you to have walk-ins. So your population, your church clergy, everyone could come out and get vaccinated. And that has done had tremendous effect in the north and in the south end of Hartford. Still lots of work to be done around hesitancies, but I think we're moving the needle. As far as the work that we're doing here at the community health centers, we've partnered with the Hartford Foundation for Public Giving and one of our community impact nonprofits, CRT, and we are doing continuously doing vaccine clinics, mobile clinics, whether it's at churches, clinics, small business organizations, farms, all across the north end of Hartford, Bloomfield, Windsor, Manchester, South Windsor. We are doing the work on the ground, and I think the more education that you provide and partnerships is going to have a tremendous impact from communities of color.
Okay, well, sometime we have to go do an event at the North End. So I grew up on Holcomb Street when I was born. So that's where I was born and raised in Holcomb Street before the move to West Hartford.
Would love to have you. I think partnering with community health centers and our community partner CRT, I think we can do a lot of good work. One more thing that I neglected to say, that we also, when I was at Trinity, did something called the 24-hour Vaxathon. And so for 24 hours, we vaccinated people of color. We went to a community agency that was familiar to communities of color, trusted partner. We went to the Artist Collective, and for 24 hours, we vaccinated our community. That was sponsored by a community philanthropist who is on the board at Trinity, and she did, underwrite Joanne Price underwrote the event, and it was successful, and it had a huge impact.
These are the stories that need to be told, right? Because that's where lives are being saved right now, and so thank you so much for that incredible work.
Thank you.
One of the things I wanted to sort of piggyback on the whole discussion on education, right? And so the problem is our healthcare system doesn't make sense not only to patients, but to also those of us who are providing care in the healthcare system, right? And so let me give you a few examples. So, I had to get a CAT scan last year for kidney stones, and I talked about this in my TED Talk that I gave in December. But it cost me, despite having a health benefit, it cost me about $1,200. But the same CAT scan can be taken by someone without using their health benefit for $300. I had a patient of mine who takes an asthma medication and pays extra for a GoodRx subscription and everything, and she pays $140, but the same medication she obtains through me now at $90. So part of it is understanding how our healthcare system is designed, and none of it makes sense. So there's a big movement to demystify this, but I think, the way I view it is healthcare is very local, and so you need your local doctor to stand up and be a leader and help educate the local community, which is what I try to do. And part of the reason why I launched my podcast called 4 Elements of Healthcare, to look at healthcare through the lens of the patient. And so there's a lot of, we're seeing more and more of this with healthcare price transparency coming out. But I think number one, it's just really for people to understand, why are we where we are, right? And insurance has a place, but I ask everyone the same question, right? For things like an oil change, you don't use your car insurance. For a faucet repair, you don't use homeowners insurance. So why do we pay $120 despite having health insurance to be told we have a cold and have a nice day and take rest? None of this makes sense. So you really have to step back and begin to say, what is the service and how am I paying for it? And do I want to pay for a low-cost service with a high-cost benefit? And so as a consumer, I just don't think there's a lot of understanding as to what choices you have. And so number one, it's really just saying, all right, let's encourage people on their choices. Number two, it's, the role of the doctor is not just to spend 5 minutes and say, have a nice day. The role of the doctor is to be your guide to using the healthcare system. And so when my patients reach out to me, I'm like, yeah, this is something I can handle. This is something as an urgent care. This is an ER. And this is a specialist. This is an e-consult. So it's helping the patients use the system the right way. But if your healthcare providers are not educated on the system, then that's a problem. And then moreover, you've got a model where you've got over 40% of your physicians in burnout because of the model, and you don't have time. So you really have to go back, and I think the consumer has to understand that our system is built in a truly sick model, not in a preventive model. A preventive model is local, more time, and tangential. There's a beautiful article I read the other day on how primary care is very different than specialty care, where you're sort of meeting, where you're trying to go through a particular protocol. Primary care is a very tangential narrative, and you have to be willing to go through that experience with the patient, and that's the only way you're going to help them learn about the system.
Yeah, so we have opened Pandora's box right now. There's so many things that we've touched on that deserve a deeper dive here. You know, as we're on the topic of the way our medical system is structured here in the States and the impact that it has on pretty much all consumers, particularly consumers of color. Because when you look at the data and you look at the anecdotal, the anecdotal data and the exhaustive studies that have been done on it, people of color are reported to have, disparities or face disparities in diagnosis, in treatment, and in their outcomes. Why do you think these differences exist? Now, and even in the costs that they face for paying for the care, as a fourth difference.
A big piece of a lot of it is understanding the cultural backdrop, right? And so, let's go back to sort of science, right? And, Dr. Hotez might be able to give, people always talk about, well, this study, that study, all that stuff. So at the end of the day, though, when you're applying a study to a population, you have to make sure it makes sense. Right. If there were no individuals of African-American descent in a particular population, you may not want to apply that conclusion to that particular population. So I think that, first, we've got sort of the scientific process and what study applies to whom. And the job of the clinician is also to critically appraise that piece of it. Then there's a whole big element of cultural competency and understanding, right? So I come from an Indian descent, and we have a lot of diabetes and heart disease, but if you go tell an Indian don't have rice or roti for the rest of your life, I mean, that's just not going to work. So you've got to, so when these recommendations come out, you have to be able to say, how do I engage the person in the context of their culture so that the recommendation makes sense and they're likely to do it? And that's one of the biggest problems, is that it only comes through experience, where I've worked with tons of folks who are from Africa, who are from Latin America, when we talk about diet and exercise and things that are of value, we go into their lives, into their homes, by way of just understanding their culture, to say, hey, here's something you can tweak, right? This, adobo may have a lot of sodium in there. Did you know that? So, but there's that, none of that is taught in medical school or residency. And so when we're talking about different cultures and minorities, it really has to come to, how do we educate our clinicians to be able to put themselves in that culture to understand it? So I in Rochester Medical School, we had the largest deaf community in the country, right? And so, but yet as a medical student, I was never taught, what about sign language? How do you work with the deaf community? Is it a capital D? Is it a lowercase d, right? And so I created it in our medical school, a curriculum for deaf health pathways. So you've got to identify what your community is lacking, but you've got to then be able to say, how do I create this so that the community finds value to it and it addresses these competency gaps?
Yeah, no, I totally agree with that. I think the other overlay on this is poverty. I thought I knew what poverty looked like living in the Northeast, but poverty down here on the Gulf Coast, it's a different world. It's quite extreme. And the poverty that I see here in parts of Texas, Louisiana, look like the kind of poverty I would see, working all over the world, where we have a lot of parasitic and tropical diseases. And we started looking into this, and we actually came up with that there's tens of millions of Americans living in extreme poverty. We had the United Nations Special Rapporteur for Poverty visit our part of the country back in 2017, and the estimates are that there's 18.5 million Americans that live in what's called extreme poverty, that is half the US poverty level, and another 5 million Americans living on less than $2 a day, the same benchmark you would use for global poverty everywhere. So we forget that there is this, and a lot of the poverty is hidden or it's covered up, so people don't know it. And poverty is still one of the greatest determinants or drivers of disease because of lack of health care, poor diet. But also, we found a lot of neglected tropical diseases among the poor here in Texas, and diseases that people said are only imported from across the southern border or imported from abroad, but we're finding transmission of diseases like Chagas disease and toxoplasmosis and typhus. And what's interesting is that's been one of the hardest messages to get through, that we have this severe level of poverty in the US and poverty related neglected tropical diseases. So I can get more support and interest among diseases of the poor in Africa than I can in the United States. And I'm never sure I quite understand why. Finally, we got Senator Cory Booker to put some legislation from New Jersey to put some legislation in place about, addressing diseases of the poor, but it's still a very tough sell to get people to accept. And, I don't know if it's because people just don't want to believe that this level of poverty exists in the United States, or this concept of American exceptionalism, what it is, but it has been really problematic. And of course, when it comes to access to COVID-19 information, we have communities here in Houston, for instance, that are just very insular and don't even have much connection to TV, or they don't have internet connections, and all of this is compounding. But poverty is a huge driver right now.
Yeah, so it's really interesting, poverty being a driver, and the unwillingness or the lack of direction to view the problem as an American problem, right? Because one of the things that seems to be a recurring thing is the idea of information and education, right? Like getting the information and education out to people. And we tend to learn, most of us, by word of mouth. Most people don't research things, look them up, or may not have access to research things to look them up. And even when you talk about getting the information out to people and understanding that these diseases, which are neglected tropical diseases for the most part, are impacting American communities, it's hard for the average American to wrap their head around it, because we're the #1 country in the world. We have the #1 healthcare system, and we have the best of the best. How can our people be suffering? It's unlikely, or it's illogical. But then I think back about my own mind and moving to Connecticut. And when I first moved here almost 20 years ago, I think because of the income disparities, Connecticut had the second number of kids below the poverty line, right behind Mississippi at the time. That's hard for people to grasp who come from outside, and their image of Connecticut is wealth and of privilege. And then you take a trip to the North End, or you take a trip down to Bridgeport, or you take a trip down to various areas of Connecticut, and you see that not everyone lives that lavish lifestyle. So the same holds true in pockets and communities all across the United States. And because we have this resistance to absorb that information, we also have this resistance to do something about the problems.
That's right. I think it's a great point. In Connecticut, it's very much an urban suburban divide. As you point out, you go into parts of Bridgeport and New Haven or Waterbury or Hartford, and the poverty is pretty intense, and you can literally drive 2 miles beyond that, and then you're in very wealthy suburbs. So it's quite impressive. And then there's definitely a color divide as well, and that's really concerning. So providing access to these populations is so critically important.
No, thank you for that. In terms of combating, the lack of information, because one of the things, anyone who's watched these colorful conversations has heard me say that it's one thing to ask for access to a room, but if you don't know the building exists, it's near impossible. right? How do we give people to recognize the building, let alone get them access to the room where they get the information? You know, so we've heard a little bit about, the community outreach and the door knocking. What other ways are there to get the information in the hands of people, and to kind of build that word of mouth, so that we get the groundswell that's necessary to make the changes?
Well, I think it's interesting because I'm not sure that I think the ideas have to come from members within that community, because every community is going to be approached slightly differently, right? So, for example, when I was looking at sharing information about my practice to the Polish community, the idea came from someone from the community and said, hey, you know what? Polish people like to read this newspaper. Why don't you do something here, right? And so I think oftentimes, the answer isn't sitting in a room or in a boardroom and saying, well, how are we going to engage with the community? It's actually engaging with someone from the community and asking them, well, how does the community respond and how would you do it, right? And I think that's one of the things that I have learned through my sort of journey as when I was an executive and things, is you have to go down to the grassroots and you've got to say, how can you influence people, and ask the people who are in the community, and they will tell you the best way.
So essentially create an advocacy class.
Yep. So I agree. I think one of the things that can help us is an investment in more community health workers. From my experience working in healthcare over the last 6 years, is that door to door, right? Working with the communities. Folks ask me how I've been successful in getting people vaccinated, getting people to access federally qualified health centers and going to primary care physicians and dental clinics. And that's just, reaching out to trusted voices, whether it's working with the local ice cream truck, Ice Cream for a Dream, and saying, hey, we're going to do ice cream for a vaccine, right? And having, Matt Rivera go out and help drive the and drive the work that we're doing around vaccine outreach to the homeless population, right? Because when you look at his truck, most of the homeless folks, come up and tell him their dreams, and so they trust him, right? Going to Union Baptist Church, right? Going to Alpha Fraternity Incorporated, going to CRT, going to Advocacy to Legacy, right? Going to the West Indian Foundation and the Social Club, right? Because they have a catchment population that trusts them, and being able to empower them to articulate the resources that that building has that benefits their community, right? Not just giving them the information, but also seeing people that look like them in those buildings, make them comfortable. And I think if we continue to invest in those things and providing, access, going outside of the walls of healthcare, going outside of the traditional medical clinics, right? COVID showed me that, right? If DPH, the Department of Public Health, and all these other organizations could allow us to provide vaccines on, at basketball courts, inside buildings, anywhere on the side of the road, right? Why can't we provide healthcare like
Yeah,
I think the other piece of this is that the targeting of the disinformation is really concerning me. We've had a lot of discussions on the news now about Facebook, and so the social media companies and the techs, and the Surgeon General Vivek Murthy has talked about the role of Facebook, and I've spoken with him as well. And clearly, the social media giants have had a role in disseminating a lot of disinformation, but it doesn't get to the source, and that's I think the next piece that we're going to have to tackle. That there are at least a dozen non-governmental organizations, which the Center for Countering Digital Hate. It's amazing we have to have something called the Center for Countering Digital Hate. It's run by Imran Ahmed, who's a friend who's based in Washington, D.C. They've identified a dozen organizations that they call the Disinformation Dozen that are monetizing the internet, selling fake nutritional supplements, fake autism cures, peddling fake books on Amazon. When you look at books on vaccinations, for instance, at Amazon, my book is one of the top pro-vaccine books on selling on Amazon. It's ranked about 27 because it's 26 fake anti-vaccine books and COVID conspiracy books ahead of it. So this is what we're up against. And I don't even call it misinformation or disinformation anymore. I call it what it is, which is anti-science aggression. And it is aggression, and it's a killer. I mean, when you look at what's happened with this Delta wave since the summer, we've lost 100,000 Americans from COVID-19, despite the widespread availability of safe and effective vaccines. So these were, it's extraordinary if you think about it, 100,000 unnecessary deaths. It's 100,000 deaths by anti-science, people who are defiant of vaccines, refusing vaccines because they themselves are victims of this anti-science aggression or disinformation or whatever you want to call it. And so I think we have to look at that whole space in a new way. I mean, I think the traditional way of doing this, and it's still important to do it, is to try to amplify our pro-vaccine message or our pro-health message as much as possible. But at some point, we have to realize that a lot of these are messages in a bottle floating in the Atlantic Ocean. We've got to do something about the Atlantic Ocean, which is dominating the internet. The anti-vaccine disinformation dominates conservative news outlets at night. And it's not only just targeting the science to create this false alternative narrative that ivermectin is just as good in this nonsense, but also targeting scientists. I've had, Laura Ingraham and Fox News go after me with the governor of Florida. I mean, I think of the governor of Florida. I don't even have any connection to Florida, and the governor of Florida's going after me. And so this is a new age that we're in, and how we can get our pro-health voices heard, I think is going to be really important. So what Dr. Kankarayam is doing is absolutely very noble, and it's saving lives. And we need 100,000 more of them. But in the meantime, we also have to do something about dismantling the disinformation empire, and that's what people don't want to do, because the minute you talk to elected leaders in government about trying to take down the monster, that makes people very uncomfortable. So we still need a way to launch that counteroffensive against the disinformation empire.
So it's interesting when you think about this disinformation empire. You think about the advent of the internet, right? For those of us who are on the call who are old enough to remember the world prior to the internet, and it being developed and us having access and looking at it as this way to now have access to all known human information. Yeah, some things are going to be lost in the sand at times. Some things are going to be redacted and kept secret, but all known human information, is available at our fingertips. And rather than connecting us in this modern age, it's become a tool to keep us siloed, right? And to keep these pockets of misinformation, in kingdoms unto themselves. So why do you think there's a resistance from politicians and large corporations and people who potentially have power to knock down those walls? Why do you think that resistance exists?
I think, part of it is they don't want to be accused of violating First Amendment rights, even though these are non-governmental groups. And I've seen it firsthand. The minute I start talking about how we've got to take down the sources of the disinformation and aggression, remember what I'm doing. I'm interfering with the business, right? That's hurting their bottom line, and that then they distort my message, and they use it as a dog whistle to call it the troops, and the troops attack me on the internet. And they say the army of patriots is going to come hunt me down, and how do you respond to that? So I mean, I try to use some humor. I say, look, you don't need a whole army of patriots. It's just me and Anne and Rachel and the cat now. I mean, you could probably just get away with one patriot or two patriots. You don't need a whole army of patriots, but you get the idea. I mean, they and then they're very aggressive. They use a lot of anti-Semitism, also a lot of because they know I'm Jewish, and so a lot of Nazi images, a lot of Nuremberg hangings. So we've had to bring in the Houston Police Department and the Anti-Defamation League. So it's taken this very dark turn, and very quickly. and I don't really know where it's all going to go, but there's clearly an element coming from political extremism on the right, and this kind of started about 6-7 years ago, even before the pandemic, around these concepts of health freedom, medical freedom, and it unfortunately started here in Texas, but now it's nationally, and you've seen it up in Connecticut with all the anti-vaccine rallies at the Capitol. Again, under this fake banner, health freedom, medical freedom, it all came out of this political pivot that the anti-vaccine groups made around 2015 to re-energize. They needed to get PAC money, they needed to get political contributions, and it worked. But it's had a devastating effect on the country now, as you see, not only people of color distrusting the government, but you've got a lot of those 100,000 Americans are coming from conservative groups who somehow, in this very self-defeating way, see not getting vaccinated as a form of allegiance to the tribe or allegiance to whatever it is they're promoting, and saying they want ivermectin instead of vaccines, when ivermectin actually has no impact at all. So this is, and then of course, that's not complicated enough. Now from British and U.S. intelligence, we've got the Russian government that's using this as a wedge issue to destabilize our democracies, and they're filling our internet with a lot of fake messages as well. So this has become a very complicated ecosystem very quickly. And what I've asked the Biden administration to do is look at how we can create some kind of interagency task force, because it's gone beyond the health sector. We've got to bring in the Justice Department, the Commerce Department. We've got to bring in the State Department, Homeland Security, if we're really going to address this. And I make the point and I said, look, 100,000 Americans since May have died from anti-science, and so when you think about the things that we spend a lot of money to put infrastructure to combat, like whether it's terrorism or cyber attacks or nuclear proliferation, heck, anti-science has killed more than all those things combined, and yet we've not been willing to put infrastructure in place. And I think we have to have that kind of awakening.
And when you look at these programs of anti-science, and of course, 100,000 Americans, that's affecting across communities. But it seems, at least in things that I've read and I've seen, that a lot of these efforts are also targeting communities of color based on the distrust that you mentioned that exists. We use examples of the disparities that people face when they go in and seek care, or being misled by things that have happened in the past, like the Tuskegee experiments. How do we insulate these communities of color from this anti-science, as you put it?
Yeah, no, this is the other piece, that there is this targeting of communities of color, and the fake documentary that's caused a lot of damage. And the anti-vaccine groups even before the pandemic, held these what they called Harlem vaccine forums, and in New York, and they just filled it with outright disinformation and tried to discourage people of color from vaccinating their kids. And now this is all amplified. They even held one rally in the Riverside Church on the Upper West Side of New York, which, as we know, is one of the iconic churches in the history of the civil rights movement, Reverend Sloan Coffin. And so this kind of targeting is really concerning. How do you combat it? Well, I think, the kind of programs that, Kenneth Clary mentioned, I think that's a big start, bringing in the clergy. I think that's, shining a spotlight on it, I think is a huge benefit. But I also think we do need to start deplatforming some of the disinformation groups, because they're causing so much damage, and really looking at what's coming on from the far right-wing extremist groups, and recognizing that this is one of their new weapons of choice, is anti-science disinformation.
So is this exclusively an American problem?
Well,
And
it's going global. So now, for instance, Canada, which has never really had much of an anti-vaccine movement, Now we're seeing anti-vaccine protests in Vancouver and Ontario, and this, if you look at what's on the signs, it's the same sort of garbagey health freedom language, medical freedom language that you see down here. So that's exporting. Then, we've had anti-vaccine, anti-mask rallies in the European capitals, in Paris and London, Berlin, and New York Times and BBC's reported it's linked to QAnon and even neo-Nazi groups. So it is being exported, and it's being exported to the African continent as well. And we even have Putin now trying to discredit the J&J vaccine and the AstraZeneca vaccine, which are both adenovirus vectored vaccines, because he sees it as competition with Sputnik V, the Russian adenovirus vectored vaccine. So this is now a globalized phenomenon, and I think not all of it, but a lot of it came out of the U.S. So we're good at we export our culture, right? We export our movies, we export our music. Now we're exporting this garbage.
One of the things I find interesting. So I have some of my patients who are very hesitant with the COVID vaccine, right? And I think and they've got their viewpoints. But I've learned, one thing as a physician is, if I come in very hard-handed, and the approach isn't sensitive, it will create even more of a divide. So I've had my patients send me links. Hey doc, like, this is the video, and I have sat through watching those documentaries. I have read all of those articles, because when I give my opinion, I need my patient to know that I considered theirs, right? And I can't just come with one lens. I have to go into their lens and then give my thoughts on what that lens might be.
I think you're absolutely right, because otherwise you're just part of the conspiracy, right? So,
and we may arrive at different conclusions, but it's my approach to healthcare has evolved, where I'm not going to penalize you if you don't want a vaccine, right? That's not my role as your primary care doctor. My role is to help educate what I know. Here's what I believe in. Here's what makes sense to me. And it's to share that with you so that you can take that information and make the best decision for your life.
Remember, they are victims of disinformation, and that's the way I like to treat it as, and to try to get them to understand, that they are being targeted. But it's tough. I mean, it all varies. I'd say the majority of individuals that I've spoken to, you can explain it to them, and they'll take their COVID vaccines. But then there's this minority, I don't know what it is, 10, 15, 20% that are deeply dug in and totally bought into the conspiracies. That they're really tough to reach.
I agree.
But I think what you should, like I said, for me, you have to give them the space to express their thoughts and concerns, because if you do not do that in healthcare, we are going to worsen it comes at the cost of the relationship between the doctor and the patient.
I agree, right? Because I was on the ground, right? So I did the day-to-day work in the communities, and I think you're spot on. You have to listen to them. You have to be understanding of their viewpoint, because too often, right, we come in suits with PhDs behind our names and MDs behind our name, and folks are intimidated by it, like, oh, we know best for them. So I think a lot of it is just listening, providing the facts, and not just providing the facts, but going outside of the traditional media points of where you're delivering that information. So I can give you a concrete point. So, I worked for a big healthcare ministry here in Connecticut prior to joining CHC. And our marketing and communications, not talking bad about them, but our marketing communications department, to me, in my view, kind of had this position on, we're not going outside of the traditional media circuits of the NBC, the Fox 61s, the traditional Facebook and Instagram, right? And I was like, hey, we need to go on TikTok, because most of these people are getting their information from TikTok. A lot of these podcasts where it's just a couple who are on not Facebook, but YouTube, or on the local AM radio, because they're not licensed by the FCC. So they have this, bootleg radio station that's, in the corner in somebody's basement, and they have 50 people listening to them. And I said, we need to go outside of the traditional media, and we need to put, our CEO, or we need to put a doctor or a nurse or a pastor on this. We need to spend money in the North End Agent. We need to spend money in the local papers and not the traditional Hartford Current newspaper. We need to go outside of the traditional means of which we're communicating to people and put this information on, because if you do the research, you'll see that, yeah, Facebook plays a big role in it. Instagram plays a big role in it also. But there are these local podcasts, these local newspapers that are spewing out this information that is not factual, and people are listening to it. I take a look at my own cousins, right? When, I'm telling my family members, hey, you got to get vaccinated. I'm one of the guys in the North End leading the efforts of getting Black and brown people vaccinated. And I couldn't even do outreach to my cousins because they bought into this mistrust and the conspiracy theories. And I say, hey, where are you getting your information? And it was on these little mom and pop radio stations that had no regulations from the FCC or any of the commercial media outlets. And I was like, hey, Barry, you're getting you're misinformed. Here's the facts. And I think when I presented it to him, he got vaccinated. So I think my larger point is just to go outside of the means of the traditional Facebook, Instagram.
Yeah, it's a great point. Unfortunately, I'm going to have to run. I'm getting called. So, but I really appreciate this opportunity. It was great to meet everybody, and thank you. Maybe we'll do a follow-up again in a month or two, but I really appreciate the chance to speak with everybody.
Dr. Hotez, thank you for joining us. We appreciate your contribution.
Bye-bye. Keep
Take
up all
care.
your great work. Thank you. Bye-bye.
Ken, you make a really great point. It goes back to what I was saying earlier about the word of mouth thing, right? And that's what it's become in this digital age. Informal podcasts, YouTubers, people getting information from communities that they trust, and that that they find something in common with. So people that the information resonates, that provide information that resonates with them. And also the idea of the approach, right? How do you approach people, and how do you get them to rethink things? Because I think about a life lesson that I was taught many years ago, and it was one of my good friends and mentors, from Kentucky, and he said to me, the worst thing you could do to a man is steal his religion.
Mm-hmm.
Meaning, you can be absolutely right, and you can have data and facts and logic behind you, but if you sit there, disprove what somebody believes while calling them a dummy to their face, they are going to be less likely to receive the information that you put in front of them. So they may know logically that they are incorrect in their belief system, but they're going to dig in deeper and find a reason why whatever you said can be discounted and discredited. So it's definitely a part of the approach.
Yep, I wholeheartedly agree. I take it as right, if your pastor, right, you go to church, you listen to him every Sunday, he tells you to tithe, right, and it's like somebody going in and saying, Pastor, to me, my pastor's wrong about what he's saying from the pulpit, right? I trust him. He's my trusted voice. He's my spiritual leader, and if it's a culture shock, and so I think we have to be very delicate on how we approach it. To the doctor's point, we have to hear people. We have to provide as much information, get as many trusted leaders in the community out there, spend money on the issue, provide the information. And I think once you do it, it's not going to happen overnight, but you continue to chip at it, one patient, one person at a time. I think we'll get there.
So, Dr. Kankuriam, I'd like to turn to you for a second and talk a little bit about your approach to dealing with your clients and dealing with your patients, because you mentioned the time and effort that you spend with them. A 2-hour doctor's visit, that's a long time for the average person. Right? We're not. You spend maybe 2 hours waiting to see your doctor for that 5-minute visit in general, right? So this is truly sounds like an innovative approach. Can you tell us a bit more about how you came to structure this and the impact that it's having with the communities that you're dealing with?
Yeah, so it's the concept is not new, right? Because I mean, if you go back in time, that's kind of what was happening. We've just sort of lost it over time, but there was a revival about 10 years ago, a movement across the country in a model called direct primary care. And that sort of, and those of us who work in it make up less than 1% of doctors across the country. So we're very small, but it's a very grassroots, local healthcare model where we're basically saying, you know what, like, let's not use high cost healthcare benefits like insurance for low cost services. Let's go back in time and make it direct cash pay, but then let's go a step further and make it subscription. So now all of a sudden you're not worried about how much is this going to cost me every time you seek healthcare. So the concept is really basic. It's about removing barriers. It's about giving the doctor more autonomy to practice the way you want to. So those of us who do it, for the vast majority, we're independent. So we are local business owners. We run our own practices. We keep a very lean model. We engage with our local community. And the model is designed so that as a doctor, I'm not incentivized to bill more and charge you more just to make more money, right? Because at the end, in the real world, as a doctor, the way you're paid is by how much money you generate the company, right? And so if you see X number of patients, you get paid more. If you, you're looked at how many referrals you make and all these different things. Whereas for me, ultimately, it's what my patients, what they need, right? And so as my patients stay members in my practice and they're satisfied with the care that I give them and they believe I give them high quality care, that's how I get paid. So as a doc, now I'm not incentivized to do things that benefit a corporation. I'm incentivized to do things that are right for my patient. And part of that is also helping them save money on things that they shouldn't be paying a lot more for. So talking about money with my patients is very, very common. Most doctors do not talk money at, most doctors don't even know, I didn't even know how much things cost, but now I do. So when I'm talking with my patients and I have, a guy who works construction and needs a sleep study, I can tell him, well, if you go here, it'll probably cost you about $600. If you go here, I can get you a sleep study for $199. So these are all the things that we talk about social determinants of health. And we design a model where we have a bunch of other people working with the doctor, but oftentimes that information never makes it back to the doctor so that the doctor can use it. So in this model, I am gathering those social determinants myself. I'm talking about environmental exposures. I'm talking about poverty. I'm talking about, do you have enough, what kind of foods do you have access to? So it's really, in a way, old school, but it's hitting all those different social determinants of health that I need. Because Chris, if I were to make you a recommendation, it might be very different than what I make Jesse based on your home and your personal situation. That is the core of medicine. And that's how you begin to say, this is not cookie cutter. It's not the same referral that Chris gets and Jesse gets and Ken or Chris or Kate, right? Everyone gets what they need for their clinical scenario. And that requires time and it requires removing biases, right? One of the biases is what insurance is going to pay for. The other bias is, as a doctor, who are my obligations, right? And I ask everyone this, as a doctor, who are you paid for? Your loyalty is likely who you are paid for. Are you paid by your employer or are you paid by your insurance? In my case, I am paid by my patient only.
So that's huge, right? That is incredible information and an incredible approach. And it's kind of startling that only 1% of physicians have adopted this, right? Because in the model that you're describing and the approach that you're using, by becoming and not becoming an educated physician, because it takes a lot of education to become a physician, but by changing the way that we educate physicians, we are now creating educated consumers.
Yes.
And we're now creating a model where people can learn more and become more cost efficient in navigating the system as it stands right now. How do you see this impacting the future of the system? Do you see the system catching on and changing?
Yeah.
Do you think it's tenable in the way that it is right now?
So when people ask how this is going to scale, right, my answer is it doesn't and it shouldn't, not in the same ways we think of scale, right? So scale is mass scale, cookie cutter, everyone, kind of has to do the same thing. But this is so individualized. So one doctor's practice is different than the other. And that's how it should be, right? Because our practices are extensions of who we are, our personalities, our styles. But, a couple of years ago, the Society of Actuaries did a big study on this model. And employers who offer this for their employees, you could save up to 40% of costs on your cost of care, right? You had big reductions in emergency room utilization, unnecessary specialty visits. So if everyone wins. And so, one of the really interesting things is that, Amazon is offering direct primary care as a benefit, right? They've partnered with a larger DPC company to offer this in a lot of their warehouses across the country. Many local municipalities have partnered with local independent direct primary care docs to offer this. Johns Hopkins this year opened up their first direct primary care practice for their employees. And I worked with a very large company here in Hartford 7 years ago, opening up a direct primary care practice for employees. So, there are two people who benefit, right? So you can go the individual route where individual consumers, small business owners are like, hey, this is great. And I get fantastic care. And you also have the employer market where employers can be like, whoa, wait a minute. We may not be able to offer large benefits, or even if we do, now we've got a model that helps our patients save money. It reduces the increase in premiums for employers because the less claims you have, the less premiums you have. It makes them look good. The employer looks good. The employee gets care, not waiting for 3 weeks for a sick visit. And the doctors are happy. So, at the end of the day, everyone wins. The challenge is that it takes a certain type of doctor to work in this model, because if you're the type of doc who's like, I'm going to show up to work and I want my patients to be, come in through the door and I want to leave, this is not for you. It takes an entrepreneurial spirit. It takes like, hey, I'm willing to clean my own toilets because that decreases my overhead and therefore my patients can have lower cost care. You do it. Yesterday, I was, brooming my office myself, right? And so it takes a certain personality, and that is more of the challenge. So, but part of it is educating docs to say, hey, you can have a very happy professional life that's very balanced by doing something different.
So it's just a slight change, but do you think it's something that a lot of docs will adopt, mid-practice, or are you thinking it's something that we're going to have to start teaching, physicians while they're young?
I think you've got to expose them while they're young. And that's why I actually have a lot of students, residents. I have people who shadow me to build this, because oftentimes you choose your career path early on and it's hard to pivot later. So if you think primary care is what you're used to seeing as a resident, then you may not go into primary care, right? So it's important so that at least people know these are options of ways of delivering care. There are people who enter direct primary care late in their career who've been so jaded by the system, people who come right out of residency, and then people who are like me, who have sort of been in a variety of worlds and who believe that this is a right way to do what I want to do. So, but it goes back to the whole premise of you don't know what you don't know. And if you didn't know this existed early on when you had to make critical choices, whether it's in your career or whatever it might be, then you may miss an opportunity. So that's where the education is important.
So, just being respectful of time, because I know that you and the other panelists have other commitments. I would like to close by asking a question. What information would you give to young physicians and aspiring physicians? And what information would you give to patients, to people of color who are trying to navigate our health system, who are trying to navigate the world, this COVID situation that we're finding ourselves in its various, its varying levels of intensity? What would be the parting information that you would leave them with today?
I'm not sure if that's a parting information or an invitation for a whole other lecture. No.
We will definitely have you back.
So let's go to the first question. I think what I would tell, upcoming physicians is that what they see or what they think they see medicine is not the full reality, right? And so they need to expose themselves outside the academic world of medicine, outside the hospital world of medicine, to see what you can do in medicine before you decide what you want to do, right? So that's the biggest piece that I would say. In terms of for individuals of color, one of the things that I'm a big proponent of is, before you trust your life with someone, get to know them. I'm a big fan of interviewing your doctor, your care team. You want to know if they can understand you as a person before you begin to trust them, right? Not a single patient of mine gets to be my primary care patient before they have interviewed me, because it is a conscious choice that I want them to make, right? I want them to feel empowered that, hey, you know what? This guy gets me and he can help me, right? Once that trust and that belief is established, then you can do far more with that relationship. So, I would say, it's not about the doc who's got the best ratings. It's not about the doc who, whatever outcomes you're looking at, or it's about, does the doc get to know you as a person so that they can begin to understand your culture and give you a recommendation that you are likely to follow and resonate with, as opposed to something generic.
So putting in the effort to figure out whether or not there's a fit between you as the doctor and them as the patient.
Yeah, and reflecting on yourself and saying, what do I want before I go into this visit? What are you looking for? A lot of people don't know. They just show up because, like, I think I need a physical. Well, is that what you really want? And so you've got to ask yourself, what do I want out of my health? And then who is the best partner to get there?
What is your end result hope for this meeting?
Yes.
Right. Well, Dr. Kankurian, thank you so much for joining us today. Thank you for taking the time out. Thank you for making Roti safe again. Much appreciated, because I'm not giving that up.
Awesome. No, thank you all for having me.
All right. Chris, do you want to leave them with some parting words?
Sure. We'll have to get our other panelists the recording of this so that they can personally hear me thank them. But thank you, Doctor, for all your insights today on this topic. And Chris, congratulations once again for navigating some very rough waters on some very complex topics and keeping this conversation going. So job well done there, as always. I just want to take this time to thank the other members of the chamber staff, Kate Cobes and Jesse Bouclier, for doing all the heavy lifting behind the scenes to bring this program to you. And of course, thank our sponsors, Liberty Bank, the North Star Realtors, and Comcast Business. We will see you again in 3 months. If you missed the beginning of this conversation, you can check it out on our Facebook page, and also later today will be up on our YouTube page and also at West Hartford Community Interactive. Once again, I'm Chris Conway, and thank you for joining us.